Greetings, this is Dr. Doyle, and you are viewing Module 5 on the principles of toxicokinetics. This module discusses the processes that govern the concentration of a xenobiotic in the body over time following exposure. The material in this module is a supplement to the information that you will find in Chapter 7 of the textbook. This is the same diagram showing xenobiotic distribution in the body that you have seen in the past two modules. We have previously discussed exposure and also qualitative aspects of xenobiotic absorption and distribution through the body to sites where storage, metabolism, and excretion occur. In this module, we will discuss the quantitative aspects of xenobiotic distribution and elimination. We are especially interested in the concentration of the toxic agent, whether it be the parent xenobiotic or a metabolite, at the target of toxic action over time. However, it often is not possible to actually measure this concentration in the target tissue, so we measure the plasma concentration, which is indicated as the pool in the diagram. While the plasma concentration may not be the same as that in the target tissue, the two tissues are in equilibrium and changes would be proportional in each. Many of you may be familiar with the concept of pharmacokinetics. You would be correct in assuming that the same concepts apply to toxicokinetics. After all, drugs are a type of xenobiotic. The main difference between the two disciplines is the focus. In pharmacokinetics, we are interested in what is happening to the therapeutic agent, which is often the parent compound. In toxicokinetics, we are interested in what is happening to the ultimate toxic agent, which may be the parent compound, but frequently is an activated metabolite. Also, pharmacokinetics examines the disposition of a xenobiotic, that is, a drug at low therapeutic doses, whereas toxicokinetics is examining the disposition of a xenobiotic at much higher and toxic doses. The body burden of a toxic xenobiotic is a function of several complex factors. The first listed here is the dose, which we have already been talking about in the context of exposure. As you should recall, exposure is equal to the quantity of a xenobiotic present at the body absorption site and the length of time that the xenobiotic is present at this site. This time duration factor could be a single brief episode, a continuous prolonged length of time, such as overnight inhalation of the toxic gas carbon monoxide, or it could be a dose that is delivered for short but frequent intervals, such as when a patient takes a medication 4 times daily. Of course, not all the xenobiotic at the absorptive surface is actually absorbed, and we call the proportion of the total dose that enters the systemic circulation the bioavailability. The bioavailability is, by definition, 100% for a xenobiotic that is administered intravenously, but other routes of exposure, such as through the respiratory system, can approach this level. Xenobiotics absorbed through the oral route often show reduced bioavailability because of pre-systemic elimination by hepatic metabolism. Once the xenobiotic is absorbed, it will equilibrate with the fluids within the body. Hence, the xenobiotic concentration measured in the plasma will decrease as dilution with other fluid compartments occurs. So if a 20 kilogram child was given the same dose as an 80 kilogram adult, the child would have a higher plasma concentration of the xenobiotic than would the adult, assuming other factors like absorption are the same. This is the concept of volume of distribution, which will be described shortly. We all know that when we ingest something, it usually doesn't stay in our bodies forever. As more of the xenobiotic is absorbed, the plasma concentration will soon come to a peak level and then gradually diminish. This is the elimination phase, which can be quantified by an elimination rate. Most xenobiotics have a threshold plasma concentration that is related to the toxic outcome. There is a balancing act determining toxicity between input of the xenobiotic through continued absorption, release from the storage sites, and elimination, usually in the urine or bile. Many xenobiotics are not efficiently excreted until they have undergone some metabolism. Unfortunately, it may be the metabolites that cause the greatest toxicity. The major goal of toxicokinetic analysis is to follow the plasma concentration, or even better, the target tissue concentration, of the active toxic agent following exposure. For the purpose of toxicokinetics, the term compartment relates to tissues that take up and/or release xenobiotic at rates that differ from other tissues, which would therefore be in other compartments. The tissue space defined as a compartment is not necessarily a single organ, but rather is a uniform space in the sense that the rate constants for xenobiotic exchange are the same throughout that compartment. The criterion that should be used in defining a compartment is that it is a tissue or group of tissues where the forward and reverse rates of xenobiotic exchange to other tissues are similar. Therefore, a single organ may constitute a single compartment, or this organ may contain two compartments, where one shows more rapid exchange of the xenobiotic with the central compartment, and the other compartment shows a slow exchange with the first compartment. In fact, several organs may be combined within one compartment because they have similar exchange rates with the central compartment. Generally, the blood plasma is considered part of the central compartment, from which elimination occurs by a first-order process. That is, the rate of reaction is proportional to the substrate concentration. Traditionally, the number of compartments has been determined empirically from dosed animal data. In these types of studies, the concentration of xenobiotic in plasma is plotted against time following exposure. It is now recognized that more complex mathematical, physiologically based models are more appropriate for toxicology purposes when making extrapolations from high xenobiotic doses in animals to lower doses in humans. Movement into and out of compartments is by the transmembrane flux processes that we have already described and will review here. Nonpolar gases and hydrophobic molecules move across the cell membrane barrier of the compartment by simple diffusion. Small polar molecules such as water and ethanol can also move through the membrane by passive diffusion, utilizing numerous aquaporin channels in the membrane. Larger polar molecules, charged molecules and ions, cannot cross the membrane by passive diffusion, but can be brought across the membrane by facilitated diffusion or active transport. Facilitated diffusion and active transport both utilize integral membrane proteins that have specific binding sites for the transported ligand. Therefore, these sites can demonstrate competition by other ligands and saturation at high ligand concentrations. As we will soon see, both of these interactions can affect the kinetics of xenobiotic exchange with the compartment. The apparent volume of distribution is an important toxicokinetic parameter because it can tell you much about the chemical characteristics of the xenobiotic and its interactions with body compartments. The top panel illustrates the basic concept of the apparent volume of distribution. If you were to take a milliliter of food color and add it to a beaker containing an unknown amount of water, you would see the color diminish in intensity as it diffuses throughout the water. If you knew that that food color contained 1 milligram of the coloring agent, and then you measured a sample of the water and found that the concentration of the dye in the water was 1 microgram per milliliter, then you would know that the volume of the compartment was 1,000 milliliters or 1 liter. This is pretty much what happens when a xenobiotic is injected intravenously. It first rapidly equilibrates with the central compartment in the circulatory system. If the xenobiotic was a polar molecule, maybe the size of albumin, it would stay in the central compartment until it was eliminated. We could then obtain blood samples at multiple time points after injection and plot the plasma concentration of the xenobiotic. If we then extrapolated the slope of the elimination curve back to the time of injection, we would get a value for the initial plasma xenobiotic concentration, Cp0. Since we knew the dose that was injected, we could then derive the apparent volume of distribution, V. In this case, if the study had been done in a human, we would probably come up with a volume of distribution of about 3 liters. This would be expected since the xenobiotic was unable to exchange with extravascular tissues, and the 3 liters is the plasma volume of an average adult. If we were to instead give a small nonpolar xenobiotic and do the same experimental procedure, we may find a volume of distribution of 42 liters. This would be consistent with the fact that this compound was able to freely exchange with all fluid compartments of the body, and the total body water of a 70 kilogram person is about 42 liters. Now, what if we had instead obtained an apparent volume of distribution of 250 liters? Is this possible? Did we make a mistake? In fact, it is not uncommon to have apparent volumes of distribution that greatly exceed the total body water volume. Let's take a look at the bottom panel on the slide, which will help in answering this. The container here has a dose of 10 milligrams of some substance dispersed into it, yielding a solution with a concentration of 20 milligrams per liter for this substance. Hence, the volume of distribution is 500 milliliters. If the same system has some charcoal in it, the concentration of the substance in the solution is only 2 milligrams per liter, so the calculated volume of distribution would be 5,000 milliliters. This indicates that some of the xenobiotic is no longer dispersed in the body fluids, so we cannot measure it, which results in a small denominator and a large apparent volume of distribution value in the formula. The reason why the xenobiotic is not dispersed in the fluid is because it is sequestered in some way. This is why the parameter is called an apparent volume of distribution. It may not actually indicate a real fluid volume through which the xenobiotic was distributed. It could have been bound to an extravascular tissue protein, or it could be very lipophilic and stored within fat tissue. In classic toxicokinetic modeling, the number of compartments is determined empirically by looking at the xenobiotic concentration in plasma versus time data to see if it fits a single exponential elimination function indicating a single compartment model, or if additional exponential elimination functions are needed indicating 2 or more compartments. An example of a physiologically based toxicokinetic model is shown on the right. Multiple compartments are shown which correspond to various organs having varied volumes, rate constants, and blood flow. This slide illustrates a classic single compartment toxicokinetic model. Let's look at the top panel, which shows the xenobiotic that has been injected as a bolus directly into the blood. There is a rapid equilibration of the xenobiotic between the central plasma compartment and all other tissues of the body. Therefore, distribution of the xenobiotic behaves as if there is just one tissue in the body. This does not mean that the concentration of the xenobiotic is the same in all tissues. It just means that any changes in the xenobiotic concentration in all tissues are proportional. The parent compound, or its metabolites, are eliminated from this compartment by first-order kinetics, which means that at any time the same fraction of chemical leaves the compartment, resulting in an exponential decline in the concentration within that compartment. If the logarithm of xenobiotic concentration is plotted against time, which is on a linear scale, we see a straight line. The slope of this line can provide us with the elimination constant KEL if we divide by the value 2.303. Extrapolating the slope of this line back to the abscissa provides us with the concentration within the compartment at the time of injection, or C sub 0. An important point here is that when all plasma concentration data fits a single straight line on this type of semi-log plot, you know that the system is behaving as a single compartment system. The lower panel shows the same situation when the same xenobiotic is given orally. The plasma concentration curve shows an absorption phase into the compartment, which is followed by a single exponential decline in plasma concentration. Between the two phases, the concentration of the xenobiotic in plasma reaches a maximum. This is often the point in time when toxic action occurs for non-carcinogenic xenobiotics. The elimination phase is pretty much similar to what was seen when the xenobiotic was administered intravenously. Since we are interested in the kinetics of elimination when defining compartments in the classic model, our focus is on this second phase. When this phase of the concentration data is plotted on a semi-log plot, we again see a single straight line indicating a single first-order rate of elimination from one compartment. This would be the type of toxicokinetics observed for a very lipophilic, nonpolar xenobiotic which rapidly diffuses across phospholipid membrane barriers. But you would be mistaken to always assume this type of behavior from such a compound. Additional compartments could exist if there is an increased transfer into or out of the tissue via active transport, such as by the P-glycoprotein multi-drug resistance protein 1 exporter, or if the xenobiotic becomes trapped within a compartment, such as by lysosomal trapping. This second example is a two-compartment classic toxicokinetic model. Again, the top panel represents the plasma concentration following intravenous administration, and the bottom panel represents the same compound after oral exposure. The difference between this example and the previous one is that the elimination curve is not represented as a single exponential decline, but rather as a combination of an initial rapid exponential decline due to distribution to the two compartments and a secondary slower exponential elimination from both compartments. This is the type of toxicokinetic behavior that you will find for many xenobiotics. This type of toxicokinetic behavior is most easily recognized when the data is plotted on the semi-log plot of log plasma concentration versus time. If there is more than one compartment, you will see a curve at the early time points followed by a straight line. If there are two compartments, the total data can be plotted as two exponential functions. The first exponential function with the slope of alpha describes the distribution phase. The second, with a slope of beta, describes the elimination phase. It is this second slope, the beta value, which provides the elimination rate for this xenobiotic. The toxicity of a xenobiotic is obviously related to how long it is present in the body. This is determined by the rate of elimination, but rather than talking about the elimination rate constant, we routinely use a more convenient parameter called the half-life. The half-life is the duration of time required to produce a 50% reduction in the plasma concentration of the xenobiotic. The half-life value can be readily determined from the linear portion of the log plasma concentration versus time curve. In the example shown here, the half-life would be approximately 4 hours. You may also notice that the left panel shows the clearance in a one-compartment model, and the right panel shows the clearance in what appears to be a two-compartment model. The plasma concentration versus time curves for most xenobiotics represent a two- or three-compartment model. A model with additional compartments may more accurately describe the toxicokinetics for this xenobiotic. However, the number of data points may make this difficult to resolve. One strategy for clinically managing the poison patient is to increase elimination of the toxic agent, or in other words, to decrease the half-life. An example of this is to decrease the renal absorption of weak organic acids, such as acetyl salicylic acid, by administering intravenous sodium bicarbonate to ionize the acid group. By preventing reabsorption in the kidney, an increased amount of drug is excreted in the urine, thus bringing the plasma concentration down to a safe level. The bioavailability of a xenobiotic is a parameter which indicates how much of the exposed xenobiotic is absorbed. By definition, an intravenous injection of the dose would give a bioavailability of 100%. So, to determine the bioavailability of a dose administered through the oral route, we would take the amount of xenobiotic in the plasma after absorption and divide it by the amount of xenobiotic in the plasma after direct intravenous injection. The amount of xenobiotic in the plasma can be determined by integrating the concentration over time, which is graphically called the AUC, or area under the curve. The oral dose and the intravenous dose do not need to be the same, and often the oral dose is greater if bioavailability is expected to be small. The differences in doses are normalized in the bioavailability equation by taking the cross products of the AUCs and doses. The resulting fractional value is then converted to a percentile by multiplying by 100. Saturation kinetics, sometimes called nonlinear kinetics, can occur at high exposures to xenobiotics. Saturation kinetics can be identified as a linear zero-order decrease on plasma concentration versus time curve. This differs from the usual exponential first-order decrease on the same curve. It is important to note that this linear decrease is on the linear plasma concentration versus time plot, and therefore not the same as the linear decrease that is seen for the first-order reaction on the log plasma concentration versus time plot. The change from a first-order to a zero-order process as the concentration of xenobiotic is increased is due to overwhelming a saturable process, such as binding to a transmembrane transport protein or the active site of a rate-limiting enzyme in a metabolic pathway. Saturation kinetics results in a constant rather than a proportional rate of elimination as the dose of the xenobiotic is increased further. This can result in substantial increases in xenobiotic body burden with corresponding increases in toxicity. Classic toxicokinetic models are data-driven models which show good applicability under the conditions under which the data were derived. Problems may become apparent when one tries to extrapolate these models to other scenarios. Translating the toxicokinetic parameters from one species to another is problematic. In fact, there are documented cases where differences occur within species, for example in different strains of rodents, or even between genders of the same strain and species. The toxicokinetic parameters derived within a specified dose range may not be applicable to doses outside that range, especially when saturation toxicokinetics occurs. Finally, the classic models only provide estimations of xenobiotic concentration in the central plasma compartment and not in target organs. Many of these drawbacks to the classic toxicokinetic models are addressed and to some extent overcome in the physiologically based toxicokinetic models, which we will discuss in the next module. This completes Module 5. Please test your comprehension of the material by taking the short quiz in the Module 5 folder.